Hello, you are listening to the Charles Bonnet Syndrome podcast. My name is Shaimond, and today I have a special guest host. Her name is Duchess Antoinette McDonald-Ellis, and we are welcoming Dr. Jennifer K Steeves. She's a professor at York University in Toronto, Canada, in the Department of Psychology, and she's a member of the Center for Vision Research. So how are you both doing today?
Great, thank you.
Lovely, great, a beautiful day today. Sun is shining.
That is so great. I'm just a little rainy here, and I heard it was a little rainy where Antoinette is, but we need rain sometimes. It makes a sunny day so much better, but I'm glad it's shining where you are. So can you talk a little bit about what type of doctor you are?
Sure, absolutely. I'm a cognitive neuroscientist, and my focus is in vision and visual processing, how we perceive the world, how we recognize objects and faces and color, texture, things like that. And so I am a PhD, not a medical doctor, and a lot of my time is spent doing research. And so I do different types of research. I'll measure behavior in the laboratory. I study humans as opposed to someone who might study mice, say, or some other species in the laboratory. And I use a number of different techniques. I've done a lot of measures of brain structure and brain function. And mostly what I focus on is sensory processing, vision, and a little bit of how hearing interacts with vision. In general, I would say I'm a cognitive neuroscientist. I'm in a psychology department, but I'm not a psychologist like a therapist or anything like that.
I know that you have a special focus and interest in CBS. So can you tell me when you first found out about Charles Bonnet Syndrome?
Sure. Yeah, it was an interesting progression to find out about Charles Bonnet Syndrome. I have trained PhD students and master's students, and I had a wonderful graduate student at the time named Sarah Rafiq. And together we did a really interesting study, which kind of led to where we are today, looking at Charles Bonnet Syndrome. And she actually brought Charles Bonnet Syndrome to my awareness. I hadn't heard about it. And she's actually a trained optometrist, so knows a little bit more about the clinical literature than I did, and brought an article my way which described it. And I'll tell you how it fit really well with the work that we had previously been doing. So she and I were doing a lot of brain imaging, looking at brain structure of the visual cortex. The part of the back of the head is where vision is processed initially in the brain. And we were also looking at brain function. And what we do is called functional magnetic resonance imaging, or fMRI. And with fMRI, we can look at blood flow in the brain. And I'm not sure if you've ever had an MRI or an fMRI. So what the underlying assumption with fMRI is that regions that have a lot more blood flow must be doing a lot of mental computations, because those parts of the brain are going to need a lot of energy. So you'll get your energy from putting blood flow in those parts of the brain. And so then you can correlate that with brain activity that would be related to whatever thoughts or visual images you might be looking at the same time. I had an ER doc reach out to me from California over the internet, and his wife had a stroke in the occipital part of the brain, the back of the brain that processes vision. And she was in her early 30s and had this sudden stroke and had some vision loss that was associated with that stroke, where she couldn't see. She had a scotoma, which is a blackened area of the visual field in front of her that was, I think, up in her upper left quadrant. So the upper left part of where she was looking. But all around that blackness, she had these bright flashes of light that were just absolutely exhausting. And she just really was finding it really disrupting her everyday life experience. And she was also a medical doctor, and her husband wrote to me because I have been doing some brain stimulation. And the type of brain stimulation that I do is called Transcranial Magnetic Stimulation, or TMS. And this is where you apply a magnetic field to the scalp, and it induces a transient electric field and disruption to the underlying processing within the brain of the part of the brain that you're holding this magnetic coil over. You can think of it like a really well controlled and modern day version of like a TENS machine or electroconvulsive therapy, but except that this is much more focal and localized. And so what happened was he wrote to me and explained this experience that his wife was having post having a stroke. And we corresponded over email for some time and then decided that maybe we could try applying this brain stimulation to see if we could alter her visual experience. And they flew from California and came to Toronto, where I am, for a week. And we started off and took some baseline measures to have a look at her brain structure and the brain function. And what we found was that there was an asymmetrical and very atypical activity where there was a lot of activity in the part of the brain that would have been associated with where her stroke had happened. And so we applied brain stimulation every day over the course of the week. And then we were able to reduce her experience of these flashing lights gradually over the course of the week. We did a half an hour every day of stimulation, and then she flew back to California, and it lasted for a number of weeks. And that was our proof of concept that we can use brain stimulation to modulate brain activity that might be associated with abnormal visual hallucinations. And so this experience that she had was just simple flashes of light. So when we came across this article that was around Charles Bonnet Syndrome, we thought, wow, and especially since the description of many individuals who have Charles Bonnet is often related to seeing faces or certain types of objects and textures. And what we know about how vision is processed in the brain is that there are these discrete parts of the brain that light up when you're looking at a face or light up when you're looking at objects or textures. And so what Sarah and I were thinking is maybe if we were able to test some of these individuals and we could precisely target with this non-invasive brain stimulation and try and get rid of, in particular, the hallucinations that are a negative experience. So that's the long story of how I came across Charles Bonnet syndrome.
That's really interesting, particularly to me, one who is living with CBS, because often first of all, as one who is living with CBS, it's not well known within the medical and science communities, even though it's not a new syndrome, right? But this is really exciting to me because you're showing the actual physiological, potential physiological effects that what did you call it, the TMS can have.
Yeah, that's right.
Yeah, and that's very interesting to me because I have to say, as one who is living with it, and I won't say suffering with it because I'm living with it now,
Right.
it's very frightening. Well, at first, especially when you do not know what is going on. Many medical doctors do not know because I first mentioned it to my doctor and she had no idea what was going on. So I shut it down because I didn't want to end up in some place that I didn't belong, like a ward taking drugs that left me unable to do anything else. But that's really exciting to me that you saw where, first of all, just the TMS, this whole thing is very interesting to me, where you can see the brain stimuli and what's going on. And because I've often said, I recognize that it is not actual what I am seeing, but it is real what I am seeing. Does that make sense?
Oh, absolutely. Because if it is happening, if this image is being conjured up by your brain, it is real to you. It's just that it's not real to others. We can't see it. But absolutely, I totally agree. And it's just the issue with the poor awareness of this Bonnet syndrome amongst our frontline clinicians is something that I think things like this podcast and other ways of getting the word out are going to help in future, but certainly we need to work to raise awareness so that people aren't left not knowing that there are others.
So what's the success rate of TMS?
This is a really good question. So, this is experimental at this point in time. TMS is being used clinically to treat depression. It's not being used in an application for visual disorders yet, except in this experimental research-based realm. I'm hoping that we can get there and that this could be something that could be accessible to patients with Charles Bonnet Syndrome or other types of vision disturbances that arise within the brain. But it is being used to treat depression. And I think like I don't know precisely what the success rate is for depression. I think that there are so many variables contributing to diseases that happen within the brain that there are so many different ways that you can stimulate the brain as well. There are so many factors coming together that it's going to take some time, as well as individual differences, you can imagine. But it's an emerging technology. And maybe I'll just comment to say, too, that the research in our lab, we are working towards brain stimulation. But the first step is to bring individuals with Charles Bonnet syndrome into the laboratory. And we have an MRI scanner just down the hall from my lab. And to take images of the brain so that we can look at brain structure and brain function. We need to compare individuals who are of the same age and same sex, and we need to compare quote unquote healthy individuals with other individuals who have this perhaps a similar type of vision loss, but not experiencing Charles Bonnet syndrome. And then to compare to individuals who have Charles Bonnet syndrome. So you can imagine that we need to match across the three groups, have a look at what's going on in the brain in terms of function and structure. And then that would inform how we would deliver brain stimulation so that we could do it individually for each patient so that it would be customized as to where it might be that any atypical activity might be occurring.
I do have a question about something you just said when you look at your study group. You also mentioned the same sex. So does gender also play a role in the way our brains function? I look at men and say they don't think like we do, but is that an actual thing?
Yeah, that's a great question. Yes, it's true. There are sex differences in the brain, actually. And I have published in this realm. So, one study that I did many years ago. One example of how males and females cognitively are, and I know that we have these. My husband thinks so differently from me,
Yes.
and I have to remind myself that there are sex differences and they manifest in the brain. So one way that you can measure and quantify is in terms of face recognition. So one of my students about 20 years ago did a study where we looked at performance in recognizing faces, and women outperform men. Typically, it's something that's very replicable. But then on the other hand, there are things like mental rotation. So if you have to think about the shape of something and how you would transform it in space and turn it upside down and around, men are typically better, quote unquote, better, as if it's not a value judgment, but perform with higher accuracy compared to women. And then we have actually also, this is just a complete tangent, but we've also looked at sexual orientation, and it does contribute to this effect. So we published a study years ago showing that actually men who identified as gay were actually showing that enhanced performance, both on the face recognition, which is typically a female enhanced performance relative to males, but they were also showing an enhancement in mental rotation relative to heterosexual women. So,
Wow.
Interesting question that you asked. Yeah, and I have a graduate student who's starting this fall who is going to follow up on that work.
That's exciting.
Yeah.
That's so amazing. The brain is so complex and there's so many different things, so many different layers. And it seems like with a lot of research, researchers like yourself and other people will find something and then maybe they'll change that a couple of years, a couple months later. And the brain is just so complex. We'll probably never fully understand it, but we're making a lot of progress with people like yourself and like your students. It must make you feel good to hear that a lot of your students are going on and doing a lot of work. Does that make you proud as a professor to hear all of the different things that they're doing and research and things that they're focusing on?
Oh, absolutely. I totally agree. And especially on Mother's Day, I have my biological children, but then I have my academic children as well. And I am so proud of them. It really does make me feel really pleased to know that they've learned and that they're going off and becoming independent, just as I do with my own children. So, and I, not that they're children, my students whom I've trained over the years are now into their 30s and 40s. But yes, I am very proud and happy to see that they're doing so well. And many are continuing on in research, not all, but many are.
I'm happy to hear that TMS is non-invasive, but is there any evidence to show that there are negative side effects to TMS?
That's a really good question. So it's used very carefully, and there are strict guidelines around its use. But it's not so you. I think I mentioned this earlier. You could think of the really old version that was used to treat depression was electroconvulsive shock therapy. And
Oh,
that's where you have an electric current that goes straight to your frontal lobes to help treat depression. With the thing about TMS is it's very short and transient pulses that are very discrete and targeted to a small region of the brain. It's not widespread like with electroconvulsive shock therapy. So, a few things around using TMS. There are contraindications to its use. And this includes most of the same contraindications that you would have for undergoing an MRI if you were going to get your brain scanned or your shoulder or your knee scanned in an MRI scanner. Because it is a magnetic field, you can't have a pacemaker or any metal in your body. So that's pretty much what the contraindications are. We don't use TMS with people who might have a history of seizure disorder, just to be careful. You go into it with doing very careful screening of who might be suitable for either going in an MRI scanner or for undergoing a TMS treatment.
now I have a question that's a little bit different. When I saw your bio, I noticed you also researched something called psychophysics. Can you talk a little bit about that and how that might relate to CBS?
Oh, sure. That's a really good question. So, psychophysics is just really just measurement of, so when it comes to vision, it's just measuring your visual performance. So, it could be those eye charts, like the Snellen eye chart that has the big E at the top.
Uh-huh.
That's a way of quantifying your vision. So, psychophysics is so we can break it up into physics, like measuring a quantifiable amount of something in the world. And then the psycho part is, and then how do you perceive that sensory experience that you've just quantified? With an eye chart, you start with a big letter and then you go down and make it as small as you can to figure out what an individual's acuity is, or your visual performance or your visual ability. And so what you've done is you've changed the physical property of how big the letter was, and you've systematically made it smaller until we could figure out what your limit is for your vision. And so it's just a really a unnecessary scientific term for a way of quantifying vision. Sorry, and it's not just, it's for other sensory systems as well, psychophysics. You could do it for hearing and do it for touch and taste. So it's just a unnecessary fancy word for measuring behavior, and in this case, visual behavior.
Hmm. Interesting.
Told that, oh, I'm sorry, you
No,
finish.
that's go ahead, Shimon.
I was told that different parts of the brain trigger hallucinations when you have, let's say, schizophrenia or Lewy body dementia than the Charles Bonnet Syndrome hallucinations. So I was just wondering, first of all, is that true? And then this is a three-part question. Hopefully I don't say too much at once. And then the second question is, do doctors like yourself know what part of the brain triggers CBS hallucinations? And I'll stop there. I don't want to ask too many questions at once. Yeah.
Okay. Yeah, no, and I think that is an excellent question. And that's what's driving the research that I'm doing. So it's really important and the research is just starting to come out in this realm. So there are a few studies that have looked at structure of the brain with Charles Bonnet syndrome and found a few things that look slightly different in individuals with CBS compared to, as you say, other diseases that have other origins like Lewy body or schizophrenia, I think you mentioned. It is important to differentiate between the different types of changes that there are in the brain that are associated with different types of disorders, we could call them. And yes, so I think that's exactly where we are in terms of research at this point in time is we are trying to quantify the brains and brain function to really see what is unique in terms of Charles Bonnet syndrome. Is it perhaps unique across different etiologies? Someone who suffers from Charles Bonnet following vision loss from cataract versus, say, age-related macular degeneration. Is that different? Does that result in differences in how one might see atypical brain function? So it's a great question. And I think that this is something that in the next few years, we're really going to hone in on that.
How long does TMS typically last for?
In the realm of its use to treat depression, individuals will undergo, say, an intensive certain number of weeks where they might come in, say, every day and have multiple sessions within a day over a couple of weeks to treat depression. And then people can go away for a period, but they may need to come back and just have a shorter top up where you have a shorter dose applied over a shorter period of time. And then it just boosts your brain function, your brain activity, so that it's if it's starting to go out of alignment again, then you push it back into a more typical state to try and get rid of depression. I would suspect that it could be that the same type of thing, if we are able to use TMS to treat Charles Bonnet syndrome, it could be a similar type of affair where you have an intense stimulation and then, I don't know, I'm just guessing months down the road, then you might come back for a little top up.
That's really interesting. Now, I have a question also related to TMS, and I didn't know anything really much about this, but I've seen a cancer treatment that uses brain stimulation. Is that also a TMS application?
I don't know about that. For treatment for cancer, it could also be some kind of deep brain stimulation. I know they do implantable electrodes sometimes deep into the brain, but I'm not sure about that. For some movement disorders like Parkinson's, they do implant deep into the brain, and then you can stimulate to try and get those brain structures to function in a more typical manner.
Yeah. And like I said, I didn't know much about it. And so I thought that was interesting because I saw an ad and I wish I could call forward the name of the company or the product because I thought, now that's interesting. The brain stimulation.
Yeah.
Thank you.
We keep talking about TMS because it's so fascinating, but I have another question. So when you treat your patients, do you always stimulate the same part of the brain for each patient, or is it a little bit different depending on the results or depending on the types of hallucinations they have or the gender of the person?
First, I'll just say that I haven't treated anyone with Charles Bonnet yet, but exactly what you've just said, that you would want this to be customized, individualized medicine, where you would look at each individual's brain function and how it might be best to apply brain stimulation if it were to help mitigate the disruptive hallucinations. But so far in the lab, we've only applied TMS in that single case study that I told you about at the beginning of the woman who suffered a stroke and then had these bright flashes of light. So that's the only patient. And then in the laboratory, we are able to also use TMS to do transient disruptions of processing in typical individuals, quote unquote, healthy individuals, just to tease apart. And maybe you might think of it as reverse engineering the brain to try and understand the different nodes within a network in the brain. And you can apply TMS to a node and transiently interrupt processing. And if someone is doing a visual task, it might change their ability to perform that task. And then you can infer that part of the brain that you stimulated is involved in the brain processing that's needed for that task that you're doing.
This is fascinating, though, because I'd like to share a little bit, because this has got my brain really, I wish you could see my brain right now, because I know it's shooting off all different kind of stuff of excitement. I don't know what excitement causes, but while working with my mobility trainer, she's instructing me how to use my cane. We always will put on a face mask because I have limited vision, but she always does this to assure that I cannot look at things, to train my brain. But we noticed that I had a big, and she is aware of my CBS. In fact, she's the first one to say to me, CBS, when I was telling her about what was going on. But we've noticed there was this electric box that sits very near to a street where we were walking on the ground. And it was about 5 feet from where I was walking. And both times I passed by that, she asked me what's going on. She said, because what I would normally do is I'm aware of my CBS, so I'll often just put my hand out to pop it, for lack of a better term, right? Make it go away. But she noticed that as I walked past this one particular area, she said I was doing like karate chops, and I didn't even recognize I was doing that. So we stopped on the way back, and we were trying, and she looked around because I didn't want to take off my mask. And she said, oh my goodness, we're right here by an electric box. And so we believe that because it looked very different than my other CBS events. And so that's just, as you say this, like I said, my brain is really excited right now. I wish you could put probes on it now. Because I wonder if, just like the TMS gives the stimulation, the electronic stimulation, I do believe that I don't want to say see electricity because that sounds like strange, but it does, I believe, it does affect the events I have with my CBS because of, and this happened actually at one other time. I was standing under light, again, during my mobility training, and I looked straight up. And she said, what do you see? And I tried to describe to her what I was seeing. And it was a very similar event to the electric box. And so that's when she and I put it together. Oh, the electricity must be stimulating whatever it is in my brain that causes the CBS to do something else. Wow. So all I can say to that is, wow.
Yeah, likewise. Wow, that's pretty fascinating. We need to get some of my biophysics colleagues over to have a look at that electrical box and take some measurements to see what's going on. That's pretty fascinating.
Yeah. And that's when you said that, that's the first thing, not the first thing, but as you continue to speak, I was like, wait a minute, because the first lamp was well above my head when I had the first, I don't know what to call it because it wasn't my first CBS event, but it was very different than the events I usually see. And I call them events. Some people call them critters. Some people call them whatever. I say they're CBS events because that way I'm not personalizing them.
Right.
But this box, every time I walk by, she said I was doing like karate chops, which I didn't even realize I was doing. And that's why she stopped and asked me what is going on. So yeah, we need to get some of your biophysics buds out to look at that box and see what's going on.
Yeah, because the brain, these are electrical signals that are going on inside of us. So that's really interesting, pretty fascinating.
It's amazing that everything matters. It could be, some people think that their CBS is being influenced by old thoughts and maybe even trauma if it's scary, or maybe even some good times if it's good. And it's amazing that if you have stress, it exacerbates CBS. If you don't have a lot of sleep, it exacerbates CBS. And that's one of the things that's really challenging to me, it seems, as a caregiver of someone that has CBS, is you have these hallucinations. So then you can start to develop anxiety, especially if the hallucinations are not pleasant and you're frightened. And then with the anxiety, you may not rest and you get tense, and then you don't rest good and you have more hallucinations. And it can be very challenging to deal with this. One thing that came to my mind is I would like to know, Dr. Steeves, what is something that excites you about the research that is going, whether it's your own research or someone else's research? And then the second part to that question is, if there's someone that has CBS and they're listening and they're having a difficult time with it, what would you say to maybe encourage them, whether it's medically or just in general?
Yeah, no, these are good questions. I think what excites me is what we've been talking about is looking at brain function across individuals to see if there are individual differences in brain function that could relate to how CBS manifests, those differences that might exist across individuals. And as you say, stressors can change how anybody feels. And certainly it's not surprising that it can feed into your experience with CBS events. And that it's podcasts like this and support groups like we have in Toronto that are so important to help individuals who are struggling. And I think it's wonderful that awareness is being raised through avenues like this and others, so that people are going to understand it more and more. And hopefully our frontline clinicians are as well, so that people aren't afraid to talk about what their experiences are with their frontline GP or an ophthalmologist or someone who might not have ever come across CBS before. I think it's just awareness is really important because it'll help everybody to be more understanding and more empathetic. And if we could have more empathy in the world, I think that would be a great thing.
Just all around, really.
Yeah. Yeah.
So you are one within the medical research field, and I'm so excited that you're so excited about this. You and your students, that's a small army forming right there, particularly since you deal with vision issues. But I'm curious, what caused you to really look into vision as a neuroscientist?
Oh, that's a good question. A large part of the brain is involved in visual processing. And so it was serendipity. I happened to take an undergraduate course in vision science. In psychology, it's usually a common undergraduate course to take because the way that we interact with the world is pretty heavily visual dominant. And so it's not surprising that a lot of the brain is involved in coding the world visually, although other sensory systems, we're learning more about other sensory systems as well and how they interact with vision. So it was just a complete fluke and I was hooked and I just didn't stop since then.
I'm thinking about actually the question that was coming to my mind, and I didn't want to put you on the spot, and I don't think anybody really knows this answer, is why do some medicines work for some people and some medicines don't? And why do some procedures work for some people and some people don't? And I'm thinking, as a non-medical professional, just the average person, it could have something to do with people are so different, the makeup of their body, their DNA, because there's even tests that you can take. I just found this out recently, and you can test your DNA to see how you could possibly respond to different medicines, or maybe some medicines that will have an adverse effect. And what I'm getting at is, I've been hearing a lot about this TMS, this transcranial magnetic stimulation, and people are so excited about it. And when I first found out about it, I was excited about it, and I'm still excited about it. And I like the fact that it's non-intrusive. So it's really, if you can afford it, you should try it, I think, after talking to your doctor. But I was in a CBS group, and this is one of the groups that allow people to join in that are caregivers and people with CBS. So I was in a group and I was listening to someone with CBS discuss their transcranial magnetic stimulation experience, if for lack of a better word. So they said while they were getting the procedure, all of the hallucinations went away. And then they said after they got their last procedure, they walked outside and it started snowing, and they were in Florida and it doesn't snow in Florida. So basically that was their way of letting me know that the CBS came back right away, right after the last procedure. And I don't know if that was mental. I don't know what happened. And that person went on, they passed away now, but they went on to live a life with CBS, and it was and they had a challenging, they were one of the people that were in the 33% where it was frightening and it was turning their life upside down. And then I was thinking, should I even mention that? Because that can discourage someone. But no, it's worth mentioning because I still think that shouldn't discourage you from trying it. And just because it didn't work for that person at that particular time doesn't mean it won't work for you. But I don't know if either one of you have any insight on that. The question I'm wondering is why maybe certain things may work at times and then not at other times, or work for some people and not for others. And what would you do maybe to encourage someone to try TMS, despite all of the things I just mentioned?
Yeah, no, I think you're really hitting on an important point there, that medicine is recognizing individual differences and that not everybody is the same. And this is why we're considering so many different factors, more than we used to. And when we look at individuals, you need to look at, as you say, sex. Women weren't even studied in medicine until more recently. All studies were just done on men. It was so much simpler. You didn't have to worry about women and their cycles, and that could be a factor, the hormones. I think that people are embracing differences now and recognizing individual differences and the need for customized treatments in medicine. So you've made some really good points. And that could relate to, again, CBS and how the experience is different across different individuals.
And I was thinking about, too, what you said, Shaimond. And again, of course, I'm not a medical doctor or any doctor of any sort. But from my personal experience with CBS, one of the things I learned, and I think I talked about it in group a couple of weeks ago, and maybe 4 or 5 weeks ago, I had 48 hours with no CBS events. And I thought, wow, that was glorious. But when it came back with the vengeance, I'm one who has almost constant CBS right now. I have my cherubs, and I've talked to Shaimond about that. I have a group of cherubs that will circle my head almost all the time, every day. That's not the only event I have, but that's the most persistent one. But I have found when I have times where I have, for example, I had a concert last weekend, which was in a language I do not speak. I do not speak Latin, but apparently I sing it fluently. But during the periods of time for the concert, the 2 days even between the concerts, I had very few events. But afterwards, it came back with a vengeance. And so I've noticed each time I have a lessening of the events, it seems like they come back really strong and with a vengeance. Like, we weren't there, but we're going to fill up your brain or your eyeballs or whatever we're filling up again. So I wonder if maybe that's what the TMS thing that happened with the lady you were speaking of, Shaimond, maybe because it was stimulated from outside and it prevented the CBS events, that her brain still needed to have that feedback. Because what I've learned about CBS is because I used to be a person with sight and my world had a lot to do with visual things. I'm a performance artist, I'm a writer, I'm an academic. So that all has to do with my engagement, my visual engagement with the world. And I'm thinking maybe in that particular case, and I'm not familiar with that case, Shaimond, maybe it was just that the brain wasn't getting the stimulation that it needed. And I know, Dr. Steeves, this is new technology. And so this is all kind of supposition, wondering. And as this develops more and more, I'm sure you'll know more and more about this. Maybe we could walk around with these little electronic caps on or something. I don't know.
Yeah, no, what a really interesting perspective to hear. Fascinating, isn't it?
It is fascinating. This is all fascinating.
I was going to ask earlier, and then I thought to myself, no, this is not going to be possible, but I'll just tell you anyway, my thoughts. I was going to ask, do you think we will reach a day, maybe in 10 or 20 years, where people can do TMS in their home? But when you have magnets involved and expensive equipment, I don't think that's going to be the case, because me and Eva interviewed a doctor on this podcast, and he was talking about, it was Dr. Scorin, and he was talking about the fact that they have stimulation. It's not the magnetic stimulation, but it's some kind of other stimulation that they do for the eye. And this actually will help improve the eyesight for certain people that have certain eye conditions. And then by improving the eyesight, it can help eliminate or decrease the CBS. And he said this will be available at home if it's not available at home already. So I guess it's on a much smaller scale and it's much less damaging and stuff. But that's really interesting to hear that. And there's so many things out there that are available. Is there any other procedures out there that you're familiar with, Dr. Steeves, that you want to maybe discuss, or maybe because really, we really don't know at this point. I would like to think within our lifetime, we'll have some kind of a cure for CBS, but until that day comes, it may be talk therapy. It may be cognitive behavioral therapy. It may be something natural like acupuncture and hypnosis, or it may just be talking to a good friend or going to support groups. But is there anything on the horizon that you know of beside TMS that you want to share, or that you may be aware of that you can discuss that may give some hope to helping with CBS, like a procedure or something?
Yes, it's true. You want to create a technology that's accessible to others, that they could have treatment in the home or cheaper treatment at a doctor's office. So there are different types of electrical stimulation, like advances in how electrical stimulation is delivered, and that can be a lot cheaper. The magnetic stimulation is a bit cumbersome because you have to create a really big current in order to create the magnetic field. So it's expensive equipment at present. But I think that we can always work towards, I think people are working towards in-home treatments and cheaper treatments, and you never know. Let's hope that we move in that direction, that we keep moving towards having customized treatments that are accessible for individuals, that you don't have to travel far to get it, or that you are able to maybe even afford it in-home.
Can you talk about some of your other research, even if it's not specific to CBS, because I know you've published a lot of papers and you've done a lot of research over the years. Anything special to you or something that comes to mind that you'd like to highlight now?
Sure. I've spent quite a while studying individuals who lose one eye at a young age. And what I mean by losing an eye is, at one of the hospitals in Toronto, there's an ophthalmologist who specializes in retinoblastoma. And so this is a cancer of the retina that happens typically in childhood, the first, few months or first few years of life. And one way of treating the cancer, depending upon how it progresses, there are new techniques nowadays where you can sort of have the cryotherapy and zap a tumor that is at the back of the eye. But sometimes you need to surgically remove the eye. And what that does is it prevents that tumor from progressing and getting larger and then traveling down the optic nerve to your brain, which would then, have a horrific outcome in the end. I have been looking at these individuals who lose one eye at a period when your brain is still developing. So just like we learn language after we're born, it takes many years to learn to speak and to learn your vocabulary. The same thing with vision. We don't have a mature part of the brain that processes vision until well into different aspects of vision mature at different rates. And so I have been looking at how is it that people with one eye adapt, given that they've lost half of the input to their brain, the visual part of their brain, as it's maturing. And so in broad strokes, what I can tell you is that vision is really quite good in people who lose one eye at a young age when their brain is still maturing. Some aspects of vision that aren't as good are things like perceiving movement in the world. Having two eyes seems to be related to having good perception of movement in the world. But otherwise, if you have only one eye, you have really good acuity. You are really able to see shades of, if you do tests where you try to measure your specific abilities to see very light images on a light background, people with one eye are really good at this. So then what we started to ask was, what about other sensory systems? Is it possible that maybe people who lose one eye early in life have better hearing? And so we looked at hearing ability, your ability to localize sound in the world. Where is the sound coming from? And it turns out that people with one eye are better than individuals with two eyes at locating where sounds come from. And then we've looked at the structure of the brain, and we found that some of the auditory structures in the brain are a little bit bigger in individuals with one eye. So maybe they've taken over some real estate in the brain. We've also found there's a little bit more brain function devoted to auditory visual processing. And yeah, so we see plasticity, and it's in the brain, and it's related to losing an eye early in life. In recent years, we've started testing individuals who might have lost an eye as an adult due to maybe some kind of a trauma, and we don't see the same changes. So what it suggests to us is that the brain is plastic. There's a period after we are born where it's maturing and developing, and the connections are solidifying. And if you lose one eye during that time, it's going to reroute how some of the ways that the brain is wired and the ways that the brain functions, but that it's rerouting and some of this refunctioning is really adaptive, and it's a good way of compensating for vision loss.
That's really interesting, particularly as the brain gets older and, as you say, less plastic, right?
Right.
But I'm wondering, as even for myself, and I'm seeing how my sensory cognition or compensation is starting to become almost like superpower. People will laugh, don't even whisper in the room, she'll hear everything you say. My nose, I can sniff things out from 4 blocks away. So do you think that, I don't want to go back to the TMS, but perhaps with the TMS and the further study of the sensory compensation that seems to happen in the younger people, do you think there's a way that perhaps the TMS or some other type treatment could help develop those other sensory portions of an older brain?
Sure. No, it could be. It's absolutely true. The most plasticity is when your brain is maturing, but certainly you can retrain older brains. They always say you can't teach whatever that expression
Can't
is.
teach an old dog new tricks.
Yeah, a new trick. But it's not totally true. It's not as if there isn't some plasticity, as we have to adapt as we get older. And it sounds like what you're doing is really honing in on your other senses that are really like using your hearing, using your smell, as you say, touch, taste, so that you can really take advantage of other ways to interact with the world around you and not just rely on vision.
Mm-hmm. Is it possible, though, that we all have these, and I don't want to call them super abilities, but we all have these sensory perception abilities, but because we rely so much on visual stimulation that we don't develop them, or we don't notice them, if you will? Is that possible?
Yeah. Sure. Why not? If you're and you're not being forced to use other senses, then you might just rely on vision. It's easy. Yeah. So absolutely. It's just like any ability that you practice over and over, you get better. Think about musicians who train hours a day.
Mm-hmm.
You can train yourself, athletes, train and repeat something over and over again, and you'll get better at it.
I'm thinking of people that get into horrific accidents, or they have a severe stroke and they have to relearn how to talk, or they have to relearn how to walk, and they may be 50, 60 or 70 or even older years of age or older. And so it is definitely possible to retrain the brain. Another thing that comes to my mind, I'm hoping this can relate to CBS, and I think it will. So many years ago, I was actually in the Army National Guard, and I was talking to someone that was in my unit, and they were telling me that they were a smoker. And they said that they tried everything to stop smoking and nothing worked. They tried the patch, they tried the gums, they tried everything. They went to doctors, nothing worked. So then they had a friend that was going to a hypnosis conference. And this was not even one-on-one. This was a conference with a crowded room. She said she went there not expecting anything. She sat down. The hypnosis told her what to do. She did what the hypnotist said. And she said she never smoked again in her life. And she said just the thought of a cigarette will just make her nauseous. And I was like,
Wow.
wow. So then I don't use social media a lot, but I was on social media one day and it was like a CBS page and I was looking through people, seeing what they had to say. And this one guy said that he hypnotized his mother and her CBS hallucinations had pretty much went away. Now, I'm just wondering, do we got to maybe consider some of these natural things also, because it's a possibility and it's a way of maybe possibly retraining the brain. I don't know what happens in those situations, but I know that there's some evidence that there have been some positive things that have happened. So either one of you aware of things like this, or maybe had considered some natural things, or maybe suggest that to other people?
Yeah, sure. Why not? Never rule anything out. And as a scientist, I would relish being able to study it in the laboratory so that you can really try and tease it apart and see what it is that works. Yeah, why not?
So, and for me, yeah, that is very exciting. And actually, Shaimond, I'm really more interested in a more natural kind of thing than necessarily an electronic kind of thing, because I do have metal in my head. So I wouldn't even be qualified for Dr. Steeves TMS because I do have metal in my head. So I think any holistic solution, because we've got several coping mechanisms. And if anything that can help, I think.
Wow. Yeah. One other thing that popped into my mind is that I know numerous people that developed their CBS after they had an eye surgery. And the way that I understood them explaining it to me and others when I was on the calls and things listening, is they said they had glaucoma and they had a surgery, and it was actually a successful surgery. It didn't cure it, but it was able to either preserve the eyesight or make it a little better, or they had cataracts and they got the surgery and they were able to see better. But then immediately after the surgery, sometimes that same day, sometimes 2 or 3 days later, or that week, they developed CBS. And that's one thing that always puzzled me. And I know I'm not a doctor, but I still have an opportunity to think about things and just talk about them. And that's really amazing, that something that can actually improve your eyesight, and then you can develop the CBS after. You figure you would develop it before. Now, sometimes a lot of people we were in a pandemic, so maybe they were fearful. There were some other factors that we don't know about, or maybe they didn't even mention. But do you have any insight into, maybe, have you ever heard that, doctor? First of all, Dr. Steeves, maybe some people that said, yes, I had poor eyesight for 20 years. And then after my third surgery, which was successful, I started seeing these floaters, and then it turned from floaters into people. Have you ever heard of that?
I haven't, but it could be. And the thing with vision is that we don't see just with our eyes. The eyes are connected to the eyes, bring in the information. They're the sensory end organ that's collecting light and sending it through to the back of the brain. And that is where we interpret the light information, and we are able to recognize colors and shapes and people. So it becomes more of use of the brain part of our visual system. So while the eye is part of the brain, it's not how we see. Seeing is done with the brain. So it could be that these individuals had some kind of surgery on their eye, that something was happening downstream within the parts of the brain that are used for vision that became atypical, and these hallucinations were developed. But I don't know. I have no idea.
This is all very just interesting to me. I could sit and chat with you, Dr. Steele, probably for a very long time.
Likewise, I'm really intrigued by your story and very sorry to hear that you have metal in the brain. So we couldn't bring you to Toronto for an MRI.
No.
Yeah.
Yeah, but she's a trooper. She's my hero. All the other people that have CBS, I say that they're like my heroes, because it's not easy. I know that. I listen, and something like this is definitely a challenge, but even though they have good days and bad days, like everybody, you're making it. And then also you're not, even though for someone like you, Antoinette, who pretty much you said is consistent, even if it's a cherub or something, it's consistent, but you're still going on, you're still talking today, and you even reach out to Dr. Steve. She even reaches out to people and talks to them to encourage them and be a friend to them. So I really commend you for that. And to everybody that has CBS, you're doing very well, and it's definitely not easy. So I commend you guys for your strength.
Oh, thank you.
Absolutely.
Is there anything that you would like to say in closing? It could be about CBS or not about CBS, just anything you'd like to share.
I just am really pleased to have had this opportunity to talk with you guys. And I just love it that you're creating this forum for people to hear about others' stories and to discuss. And I just think that this is so important for others, and not just for patients, but for the caregivers and for other clinicians out there in the world, so that hopefully more and more people will hear about this and understand and recognize that this is a real challenge that people are living with. So hopefully this will lead to more ideas about how to treat down the road, and that we'll have some success in improving people's quality of life.
Thank you so much. And thank you for taking the time to share and for doing the things that you do, and specifically helping the low vision community and the CBS community. I really appreciate that. If there was a clinician or maybe anybody, someone with CBS or caregiver that might have had some questions for you or want to reach out to you, is there like an email address or website that you would want to maybe leave just in case anyone might want to find out more about you or reach out to you?
Sure. It's just my last name, Steeves, Steves, at yorku.ca.
That's great. I'm sure the listeners will appreciate that. And thanks again, and definitely have a great day.
You too.